Good morning, everybody. I am Dr. Damodari. Welcome to the pharmacology class. Today's topic is gonadotropins and ovulation inducing agents. Gonadotropins are the hormones secreted by the anterior pituitary, and these are follicular stimulating hormone and luteinizing hormone. And these are having their effects on the gonads. Why they are called gonadotropins means without gonadotropins, the functions of the gonads will cease. And this is the slide showing the hypothalamo-pituitary and ovarian axis. Hypothalamus will secretes gonadotropin releasing hormone, and this gonadotropin releasing hormone, it is having their effects on anterior pituitary to stimulate the gonadotropins, that is luteinizing hormone and follicular stimulating hormone. These luteinizing hormone and follicular stimulating hormone, they are having their effects on the ovaries. So under the influence of luteinizing hormone and follicular stimulating hormone, the gonads in females, those are ovaries, and in males testes, they will stimulate the gonads to produce the sex hormones. In females, they are estrogens and progesterone, and in males, it is testosterone. And coming to the follicular stimulating hormone and luteinizing hormone. What are the functions of follicular stimulating hormone and luteinizing hormone? In males, the follicular stimulating hormone, it acts on the Sertoli cells and causes the secretion of the nutrients and proteins needed for the maturation of sperms. Thus, they indirectly helps in gametogenesis. Whereas luteinizing hormone is also known as interstitial cell stimulating hormone, because in males, it stimulates the interstitial cells of Leydig and causes the synthesis of the androgen. And from these androgens, testosterone is synthesized, and the testosterone is responsible for the gametogenesis, secondary sexual characters, and maintenance of libido in males. Whereas in females, the follicular stimulating hormone, it is responsible for the growth and development of the Graafian follicle, and it stimulates the enzyme aromatase in Graafian granulosa cells and produce the sex hormone, that is estradiol. It induces the expression of luteinizing hormone receptors in theca and granulosa cells. Coming to the functions of luteinizing hormone in females, it acts on the theca cells and produces androstenedione, which is responsible for the secondary sexual characters in females. It acts on the corpus luteum, causes the synthesis of progesterone, and it helps in the rupture of the Graafian follicle. And luteinizing hormone induces the expression of follicular stimulating hormone receptors in granulosa cells. These are the functions of the follicular stimulating hormone and luteinizing hormone in male and female. So they are important for the reproduction in males and females. The molecular weight of the follicular stimulating hormone is 33,000 and luteinizing hormone is 28,000. They are having both alpha and beta chains. The alpha chain is identical in both follicular stimulating hormone and luteinizing hormone, whereas follicular stimulating hormone, luteinizing hormone is having the same alpha chains, but they differ in the beta chain. These two hormones, they are not used therapeutically. Why? Because of their shorter duration of action, that is shortest plasma half-life, and they are destroyed by the enzymes present in the GIT. So the Gonadotropins which are used therapeutically are human chorionic gonadotropins and human menopausal gonadotropins. The human chorionic gonadotropins are extracted from the urine of the pregnant woman. The chorionic cells of the placenta, they will secrete more number of highest quantity of the chorionic gonadotropins. So they are extracted from the urine of the pregnant woman. And human menopausal gonadotropins, they are obtained from the urine of the menopausal woman. And coming to the hypothalamo-pituitary ovarian axis, there are three types of feedback mechanisms: long feedback mechanism, short feedback mechanism, and short feedback mechanisms. What are these long feedback mechanism is the sex hormones, that is estrogen and progesterone, they are having negative feedback mechanism on hypothalamus. That is long feedback mechanism. They shows negative feedback mechanism and positive feedback mechanism. Whenever the plasma levels of the estrogen and progesterone in the body is less, they stimulate the anterior pituitary to produce luteinizing hormone and follicular stimulating hormone, and at the same time they can stimulate the hypothalamus to produce gonadotropin releasing hormone. The action of sex hormones on hypothalamus is long feedback mechanism, whereas their effect on pituitary, anterior pituitary, is short feedback mechanism. And another feedback mechanism, ultra short negative feedback mechanism. So the long feedback mechanism and short feedback mechanism, it is having both positive feedback and negative feedback, whereas the ultra short negative feedback mechanism, didn't have any positive feedback mechanism. That is, the anterior pituitary hormones, they are having negative feedback mechanism on hypothalamus. That is, whenever the anterior pituitary hormones are sufficient in the blood, they shows negative feedback mechanism on hypothalamus to release the releasing hormones. In releasing the releasing hormones. This is the graph showing the levels of the follicular stimulating hormone and luteinizing hormone during menstrual cycle. And the below graph shows the levels of estrogen and estradiol and progesterone during the menstrual cycle. Usually menstrual cycle consists of two phases: follicular phase, that is a proliferative phase, and secretory phase. Proliferative phase, the proliferative phase depends upon the estradiol. Estradiol is the main hormone for the proliferative phase. Proliferation of the uterine endometrium occurs in presence of the estradiol and in presence of the follicular stimulating hormone. It is follicular stimulating hormone. It is having its effect on the ovum. So the follicular phase and the luteinizing phase. After the release of the ovum, the Graafian follicle will become corpus luteum. So follicular phase is follicular stimulating hormone is important for the proliferation of the ovum for maturation. So at the mid-cycle, ovulation usually occurs at the 10th to 13th day of the menstrual cycle. Before ovulation, the luteinizing surge will occur. After the appearance of the luteinizing surge, the ovulation will take place within 32 to 48 hours. So coming to the human chorionic gonadotropins. Human chorionic gonadotropins are extracted from the urine of the pregnant woman, and it is having both alpha and beta subunits. The beta subunit is different for the human chorionic gonadotropins and luteinizing hormone. Luteinizing hormone, it is having 121 amino acids in the beta subunit, whereas the human chorionic gonadotropins in the beta subunit, apart from the 121 amino acids, it is having extra 32 amino acids. And the preparations and doses of the human chorionic gonadotropins, it is available as 15,000 international units and 5,000 international units along with the 10 ml of the diluent. And the route of administration of human chorionic gonadotropins are, it can be given as intramuscular or subcutaneous. And they are available as recombinant human chorionic gonadotropins, human chorionic gonadotropin alpha. That is, only alpha chain is present. So it is available as 6,500 international units per 0.5 ml. And the route of administration of choriogonadotropin alpha is subcutaneous. Coming to the therapeutic use of the human chorionic gonadotropins is for induction of ovulation. So it has to be given those who are suffering with infertility. And by giving this, ovulation will occur, and this is especially used for the artificial insemination procedures. And the second use is the cryptorchism. Cryptorchidism or cryptorchism. Cryptorchism is undescended testes. For undescended testes, the treatment is, it had the testes has to be descended into the scrotal sac. If they don't descend, if they stays in the abdomen, they will get destructed and will lead to the infertility. So for this, human chorionic gonadotropins are given in the dose of 3,000 to 5,000 international units every third day, up to 4 injections every third day of the week, up to 4 injections. Third one is the delayed puberty in boys. For this condition, 500 to 1,000 international units of the HCG is given 3 times a week for 4 weeks. Fourth one is the treatment of hypogonadotropic hypogonadism. Hypogonadotropic hypogonadism, this is the condition where there is the deficiency of the pituitary hormone, that is pituitary gonadotropins. For this, the treatment is 2,000 international units are given 2 to 3 times a week for prolonged periods. Along with the human chorionic gonadotropins, addition of the human menopausal gonadotropins are needed for induction of spermatogenesis. Fifth one is the treatment of the luteal phase defects in females. Coming to the menotropins. Menotropins are the human menopausal gonadotropins obtained from the urine of the menopausal woman. And it is these menotropins are available as pure follicular stimulating hormone or combination of the follicular stimulating hormone and luteinizing hormone. Menotropins are the combination of both follicular stimulating hormone and luteinizing hormone. When purified follicular stimulating hormone is in this, only follicular stimulating hormone is present. The dose of the menotropins are 75 international units of follicular stimulating hormone and 75 international units of luteinizing hormone are available. And coming to the folitropin alpha and folitropin beta. These are the recombinant DNA monocomponents. They are available as folitropin alpha and folitropin beta of follicular stimulating hormone. The route of administration of folitropin alpha and folitropin beta are intramuscular and subcutaneous. And there is another preparation available, recombinant luteinizing hormone preparation. The name of the recombinant luteinizing hormone preparation is lutropin alpha. And the route of administration is intramuscular or subcutaneous. Coming to the therapeutic uses of the gonadotropins or human menopausal gonadotropins. Main use is for induction of ovulation in pituitary hypothalamic disorders. So it has to be given along with the human chorionic gonadotropins starting on the second or third day of the cycle. And if the follicle size attains 16 to 18 millimeters, then we have to give 5,000 to 10,000 international units of human chorionic gonadotropins intramuscularly, and it is followed by the intrauterine insemination or natural intercourse within 24 to 36 hours after giving the human chorionic gonadotropins. The second use of the gonadotropins is idiopathic oligospermia. And this is the procedure showing how artificial insemination procedures are taking place. This is the ultrasound figure of the uterus. By monitoring, artificial insemination procedures are conducted under the influence of the ultrasonography of the uterus. By monitoring the size of the ovum and ovulation, the time of the ovulation, we have to monitor through the ultrasound, and we have to inject the semen through the vagina into the uterine cavity. It is not a simple procedure. We have to monitor the levels, hormonal levels of the follicular stimulating hormone levels, luteinizing hormone levels, and estradiol and progesterone levels. And by planning the exact time of ovulation, we have to inject the sperms, that is semen, into the uterus through intravaginally. And the main adverse effect of the using of the gonadotropins, human chorionic gonadotropins and gonadotropins, is hyperstimulation syndrome. It is nothing but because of the increased levels of the follicular stimulating hormone and luteinizing hormone, they will stimulate the ovaries. And because of the hyperstimulation of the ovary will get enlarged and it is friable and prone to the rupture. So there will be increased abdominal pain, nausea and vomiting. And if rupture occurs, it will lead to ascites and shock. And this hyperstimulation syndrome is managed by conservative methods. And this hyperstimulation syndrome can be prevented by keeping the low dose of human menopausal gonadotropins and not injecting human chorionic gonadotropins along with the menotropins if plasma estradiol level exceeds 2000 picograms per ml. Coming to the ovulation inducing agents. Usually, infertility occurs in 15 to 20% of couples. Nearly 1/3 defects occur in the females and 1/3 in males, and 1/3 defects are unknown. Usually, commonly 20 to 30% of normal women ovulates spontaneously, But in general, women with anovulatory cycles, these anovulatory cycles are because of the lack of the progesterone. These anovulatory cycles and normal hypothalamo-pituitary ovarian function, fertility can be induced by clomiphene citrate, letrozole or follicular stimulating hormone or human chorionic gonadotropin combination. Previously, they have used letrozole, but letrozole is not safe drug for induction of ovulation. Only clomiphene citrate and follicular stimulating hormone and human chorionic gonadotropin hormone combinations are used for the infertility in anovulatory cycles and with normal hypothalamo pituitary ovarian axis patients and women with hypothalamic amenorrhea. In women with hypothalamic amenorrhea, administration of follicular stimulating hormone and luteinizing hormone combination is used. That is, gonadotropins are used for induction of ovulation in hypothalamic amenorrhea patients. And low doses of estrogens may be useful in cases where some follicular activity is present. Estrogens are used for the induction of ovulation in patients where follicular activity, for treating the infertility women with estrogens, there should be follicular activity. But mid-cycle luteinizing hormone peak is lacking or corpus luteum is inadequate. And progestins are not useful except in patients with inadequate corpus luteum and endometriosis. If there is defect in the corpus luteum and if endometriosis is present, endometriosis means presence of the uterine tissue, endometrial tissue outside the uterus. That is endometriosis. And dexamethasone in small doses, that is 0.25 to 0.5 milligrams per day, will induce ovulation in women suffering with polycystic ovarian syndrome. The rationale of using dexamethasone in polycystic ovarian syndrome is for suppression of the androgen contribution. Coming to the classification of ovulation inducing drugs, they are classified into first group of drugs are the synthetic gonadotropin releasing hormone analogues. Second group are synthetic gonadotropins. Those are human chorionic gonadotropins and human menopausal gonadotropins. Third group are dopamine agonists. That is bromocriptine and cabergoline. There will be hyperprolactinoma level. Prolactin levels are increased. The hyperprolactinemia will leads to infertility. So, for treatment of the hyperprolactinemia, bromocriptine is used. And the fourth group of drugs are the anti-estrogenic compounds. That is clomiphene citrate. And the fifth one are the aromatase inhibitor. That is danazole, letrozole, anastrozole, and exenestane. These are the aromatase enzyme inhibitors. Coming to the synthetic gonadotropin releasing hormone analogues. The gonadotropin releasing hormone is released from the hypothalamus and it is having its stimulating effects on the anterior pituitary to stimulate follicular stimulating hormone and luteinizing hormone. So, the gonadotropin releasing hormone analogues are gonadorelin, nefarelin, goserelin, hystrelin, desorelin, triptorelin, goserelin, and liprolide. So, gonadotropic releasing hormone is not released continuously. Its release is pulsatile manner. If continuous release is there, then it will suppress the gonadal hormones, gonads to secrete the gonadal hormones. Continuous releases should not be there. So these gonadotropin releasing hormones should be given as pulsatile manner to induce ovulation. If continuous administration is given, it will leads to infertility. This gonadorolin, the route of administration of gonadorolin is subcutaneous and intravenous. And whereas for nefarelin, it is given as intranasal. Buserelin, it can be given as subcutaneous or intranasally. Historelin and is given by subcutaneous route, and whereas desorelin is given by subcutaneous or intramuscular. The triptorelin, buserelin, and leprolide, these are the depot preparations. They can be given intramuscularly. Triptorelin can be given intramuscularly, whereas buserelin subcutaneously, and leprolide can be given by subcutaneous or intramuscular. Coming to the gonadorelin undergoes rapid enzymatic degradation. So, having very short T half, that is only 4 to 4 minutes only. And this is not preferred for therapeutic purpose, that is for the ovulation induction. It is used for the diagnostic purpose. The diagnostic purpose is to differentiate the origin of hypogonadotropic hypogonadism, whether it is defect in the hypothalamus or defect in the pituitary. For that purpose only this gonadorelin is used. The other analogues are used. The other analogues are nefarelin, buserelin, historelin. Other gonadotropic releasing hormone analogues are used therapeutic purposes. The nefarelin is 150 times more potent than gonadorelin, and it is having longer duration of action. Its T half is 2 to 6 hours due to high affinity to the receptors and resistant to the enzymatic degradation. So it is having longer T half, and it is used in pulsatile manner for ovulation induction and continuous for the precocious puberty, endometriosis, uterine fibroids, polycystic ovarian disease, and advanced carcinoma, prostate, and carcinoma of breast. Whereas coming to the triptorelin. Triptorelin is mainly used as depot IM intramuscular injection. It is used for the advanced carcinoma of breast. The triptorelin dose is 11.25 milligrams, and it has to be given of, it can work for the 3 months. And it is used for the advanced carcinoma of prostate, endometriosis, and for the treatment of the fibroids. And for infertility, the dose of the triptorelin is 0.1 milligram subcutaneously daily for 10 days from the second day of the cycle. Coming to the gonadotropin releasing hormone antagonists. Those are GnRH and CITRATE. These two are short-acting gonadotropin releasing hormone antagonists. Dagarelix and abarelix. These are the long-acting antagonists. They are used for the purpose of intrauterine insemination, that is in vitro fertilization, to inhibit the hyperstimulation of the ovaries and to suppress the endogenously released gonadotropins. These two are the main therapeutic uses of the gonadotropin releasing hormone antagonists. One is to overcome the hyperstimulation of ovaries by the gonadotropin antagonists, and to inhibit the actions of the endogenously released gonadotropins. Coming to the next drug is the clomiphene citrate. Clomiphene citrate is a partial estrogen agonist. It is well absorbed orally and it is available as 50 milligram tablets. It is having significant protein binding capacity and its T-half is 5 to 10 days. It is distributed to adipose tissue and excreted through urine and bile. Coming to the mechanism of the clomiphene citrate, it inhibits the actions of the estrogens and blocks the feedback inhibitory influence of the estrogen on hypothalamus. That is, the clomiphene citrate, it inhibits the long feedback mechanism by the estrogens on the hypothalamus, causing a surge of gonadotropins, which will lead to ovulation. What happens if the influence of the negative feedback mechanism exerted by the estrogens on hypothalamus is inhibited? There will be increased production of the luteinizing hormone and follicular stimulating hormone by the anterior pituitary under the influence of the gonadotropin releasing hormone by the hypothalamus. So there will be induction of ovulation occurs with clomiphene. It stimulates the ovulation in women with oligomenorrhea, amenorrhea, and ovulatory dysfunction. Coming to the therapeutic uses of clomiphene citrate, it is used for the induction of ovulation. The dose of clomiphene is, we have to give 50 milligrams of clomiphene citrate from 5th day for 5 days. If ovulation does not occur, the dose has to be gradually increased in the next cycle. That is 100 milligrams. If ovulation does not occur with 100 milligrams, we have to increase the dose every cycle with 50 milligrams extra. So the maximum dose is 200 milligrams per day for 5 days. Most of the women will respond with the clomiphene citrate by 1 to 2 cycles. And the second use of clomiphene citrate is for the treatment of the polycystic ovarian syndrome. So for treating polycystic ovarian syndrome, the patient has to be treated first with metformin. Metformin is the oral hypoglycemic drug, but it is having its benefits in treating polycystic ovarian syndrome. So the dose of metformin here is 500 milligrams once daily, and it has to be increased thrice daily. If it is not effective within 3 to 5 months, then clomiphene citrate has to be added along with metformin for 6 months. This is the treatment schedule of the polycystic ovarian syndrome. And the metformin should be stopped if pregnancy occurs. If ovulation occurs and pregnancy is confirmed, the metformin dose should be stopped. And if treatment fails after 12 cycles, we have to try the treatment up to 12 cycles. If ovulation does not occur, then we have to go for the gonadotropin therapy. That is with gonadotropin and agonists. Gonadotropin releasing hormone agonists. And the last option for the treatment of polycystic ovarian syndrome is cauterization of the cysts. This is the last option. And third therapeutic use of the clomiphene citrate is for treating oligospermia. And for treating oligospermia, the dose is 25 milligrams per day for 25 days in a month. And the treatment should be continued up to 3 to 6 months. What are the adverse effects of the clomiphene citrate. It causes hot flushes, gastric upset, headache, allergic skin rashes, and reversible hair loss. The reversible hair loss means whenever the treatment is stopped, there will be generation of growth of the hair will occur after stopping the drug, and there will be enlargement of the ovaries, can lead to rupture and internal bleeding. And the main disadvantage of the clomiphene citrate is it can leads to multiple pregnancies and abortions. Coming to the danazole. Danazole is a synthetic derivative of ethisterone. It has anti-gonadotropic property. It eliminates the mid-cycle gonadotropin surge. Inhibits the enzyme responsible for the estrogen production. Estrogens, they will have negative feedback mechanism on anterior pituitary and hypothalamus. So the enzyme responsible for the production of estrogen is aromatase. So this danazole, it will inhibit the enzyme aromatase. It is used for the treatment of the endometriosis, benign breast tumors, hereditary angioadenomas, and idiopathic thrombocytopenic purpura. And the letrozole, anastrozole, and the aromatase inhibitors. Letrozole is a non-steroidal aromatase inhibitor, whereas exemestane is the steroidal aromatase inhibitor. They will reduce the estrogen production, and they will release the follicular stimulating and luteinizing hormone by the anterior pituitary and helps in the ovulation induction. Because these aromatase inhibitors, they cause the fetal anomalies, and they cause arthralgia and myalgia. They are not used for the purpose of ovulation induction. They can cause ovulation induction, but because of their adverse effects, the aromatase inhibitors, danazole, letrozole, exemestane, and anastrozole, they are not used for the purpose of ovulation induction. With this, I have completed gonadotropins and ovulation inducing agents. If you are go through the textbooks, if you are having any doubt, thank you.